Radical neck dissection being the gold standard in neck dissection, we can start with the radical neck dissection or RND. Okay. So, in this case, we are removing the lymphatic group of 1 to 5. You should know the levels. So, lymphatic group 1 to 5 along with the 3 non-lymphatic structures being the sternocleidomastoid muscle, internal jugular vein and spinal accessory nerve. Okay. So, these are the structures removed in a case of radical neck dissection. And what are the indications? So, these are the indications of radical neck dissection. One is a significant, there are so many controversies going on this, but in any case, a significant operable neck disease is an indication for an RND. That means the neck node level N2A, N2B and N3. Okay. Ideally, if the primary is very large, an in-continuity resection with the primary gives a best chance for a cure. And if the what is salvage? That is, the primary is already been treated and the patient presenting with a large neck disease, then that is a salvage treatment. So, significant operable neck disease. And second, access prior to a pedicle flap reconstruction. That is, there is a huge primary with an N0 neck. Okay, N0 neck. And we want a reconstruction like a pectoralis major or latissimus dorsi. So, in that case, for access and also for staging and as an elective neck dissection, this was already discussed earlier. So, elective neck dissection or a therapeutic neck dissection for an N0 neck. In that case, we go for a radical or a modified radical neck dissection, and also for occult primary. This is also an indication for a radical or a modified radical. So, for access for staging as an elective neck dissection, and also in case of occult primary, we can go for a radical neck dissection. And these are the contraindications. That is an untreatable primary or an untreatable neck disease, distal metastasis, patient unfit for major surgeries. So, untreatable or inoperable cases, you know, they are the spread to prevertebral fascia muscles, including the brachial plexus or into the skull, the carotids, etc. They are untreatable. So, these are the contraindications for an RND. Now, what are the steps of radical neck dissection? For any surgery, the steps start with the position of patient. For any neck surgery, position is supine with the extension of the neck and head turned to the opposite side. So, to get an extension of the neck, you keep a sandbag or a pillow under the shoulders and head ring also. Okay. So that the head will be fixed in the head ring. So, supine with a sandbag under the shoulders and head turned to the opposite side. And the operating side should be away from the anesthesia machine. Okay. So, that is position. And second is incision. So, regarding incision, we discussed the decision factors in the last class. So, according to that, you decide which incision is needed, and in the neck, especially in the anterior neck, the platysma is getting inserted into the skin. Okay. So, the skin incision should be put including the platysma, and for the beginners, it is always better to mark the incision site with a marking pen, and using a number 10 blade, you put the incision in a single stroke. Okay, don't do like this. Always it should be a single stroke, and for getting more precision, it is better to keep your little finger over the skin surface and put the incision in a single stroke. Okay, so that the flap can be elevated in the subplatysmal plane, including the platysma. That is in the subplatysmal plane. if you are in the correct plane, the dissection will be very easy and the bleeding will be less. And if you are going towards the posterior aspect, that is towards the anterior border of the trapezius, the sternocleidomastoid will be directly inserted into the skin, so the dissection will be a bit difficult for you. So and in the upper flap should be up to the lower border of the mandible, and posteriorly up to exposing the anterior border of the trapezius, anteriorly exposing the up to the strap muscles will be here, and the lower flap will be up to the exposing the clavicle. Okay, and then these flaps are elevated and they are stitched to the skin or to the towel using strong silk sutures. Okay, they are maintained there with the silk sutures. And in the upper flap, the two important nerves, one is very important and the second one is less important. Both are branches of the facial nerve. The most important one is the marginal mandibular nerve and the less important one is the cervical branch of facial nerve. If you manipulate with that, there is chance of, if there is you injure that, there is chance of drooping of the corner of the mouth. So you should be very careful to preserve the marginal mandibular nerve, and this marginal mandibular nerve is going in a plane which is in between the platysma and the deep cervical fascia. So in order to preserve that, either you can, there are so many techniques. The easiest one is you incise the deep cervical fascia at the lower border of the mandible, that is to over the capsule of the mandible, and elevate the flap and keep it along with the upper flap, so that the marginal mandibular nerve will be preserved. Actually it goes 1 centimeter parallel and below the lower end of mandible. Okay, so that is regarding the elevation of the flap. So incision and elevating the flap in the subplatysmal plane, and after elevation, this is what you see. That is the this is digastric, anterior and posterior belly of digastric, and this one is the sternocleidomastoid muscle, then omohyoid and the two bellies of omohyoid, then this one external jugular vein and greater auricular nerve, and also other branches of cervical plexus. Okay, and our area of concern is this much. So after elevating area, access should be there for the 4 corners of consternation. What are the 4 corners of consternation? There are major corners and minor corners. So the major corners of consternation are, one is at the lower border of internal jugular vein. Actually the carotid sheath is lying behind the sternocleidomastoid. On elevating or retracting or the sternocleidomastoid only, you can see the carotid sheath, which includes internal jugular vein also. So the first corner of consternation is the lower end of internal jugular vein. Second comes here, that is at the junction of lower border of trapezius with the lateral half of clavicle. Okay, so the lateral half of clavicle coming and joining with the lower border of trapezius. And here comes the third corner of consternation, that is at the upper border of internal jugular vein. And the fourth corner of consternation comes here, which is the submandibular triangle. Okay, so the lower border of internal jugular, then second is the junction of trapezius with the lateral half of clavicle. Third is corner is the upper border of internal jugular vein, and the fourth here comes the submandibular triangle. Okay, so these are the major corners of consternation, and the minor corners of consternation are, one is the retropharyngeal node, then the parapharyngeal node, and third is the Chesix-Knight triangle. Chesix-Knight triangle is a triangle between the longus colli and scalenus anterior attaching to the tubercle, that is tubercle of C6, which is called the Chesixnax tubercle or the carotid tubercle, and the lower border of the Chesixnax triangle is formed by the subclavian artery. Okay, so that is the major and minor borders, corners of consternation, and after elevating the flap, this much area should be clearly accessible to the surgeon. Okay, after that, now you are seeing the sternocleidomastoid, omohyoid and external jugular vein, and we have to remove lymphatic node level 1 to 5, sternocleidomastoid, IJV and spinal accessory in a classical radical dissection, isn't it? So, the points of the levels of lymph node in this, where are they coming? The 1A is coming here, that is the submental, 1B is submandibular, and 2, 3 and 4 is along the jugular chain, isn't it? So 2A is coming here, that is at the jugular digastric, 2B is here, 2, then 3, 4 and the 5 is the posterior triangle. So all this area we have to remove the fibrofatty tissue along with the lymph nodes and sternocleidomastoid muscle, internal jugular vein and spinal accessory now in a classical radical neck dissection. Okay, so after incision we are elevating the flaps, flap elevation in a subplatysmal plane, and after that what are we doing? Actually this investing layer of deep cervical fascia is coming and covering the sternocleidomastoid on both sides. Okay, so we have to divide that fascia over the sternocleidomastoid from the sternal and clavicular head up to the tip of mastoid. Okay, so first thing you divide the fascia, and after that the lower border of sternomastoid has to be divided. By convention, there are some principles in any neck dissection, especially in a radical and modified radical neck dissection. That is, you can go from the lower border, that is from the first corner of consternation, or you can start from the second corner of consternation. Okay, either after removing the sternocleidomastoid going laterally, or from the anterior border of trapezius, removing the fibrofatty tissue, coming medially with the limit in the carotid sheath. Okay, so the principle is either go from medial to lateral, from the lower end from medial to lateral, that is from first corner to second corner, or from lateral to medial, that is from second corner to the first corner. But some surgeons prefer to go with the spinal accessory. First identifying the spinal accessory nerve at the Erb's point, then coming downwards. Okay. Then another, by convention, it is believed that it is better to first tie the major vessel, major vein, which is supplying the primary tumor. That is because when we are manipulating the primary tumor, there is a chance of microemboli releasing into the general circulation and causing systemic metastasis. If we are tying the vein which is draining the primary tumor, this chance is removed. Okay, so it is always better to go first tying the internal jugular vein, that is from the first corner of consternation. For that we have to remove the sternocleidomastoid muscle, then only we can see the carotid sheath. So the the lower border of sternocleidomastoid is removed. That is, the assistant gives traction in an upward direction and the surgeon gives a counter traction, and with a number 10 blade it is divided. Okay, so the sternocleidom, after removing the lower end of sternocleidomastoid, you can see the bluish tinge of the carotid sheath. And in the carotid sheath, internal jugular vein lies lateral and superficial to the carotid artery. So that is isolated, and at least a distance of 2 centimeters of the IJV to be at least minimum 2 centimeters of the lower end of IJV to be exposed in order to tie it. Usually we put 3 ligatures, 2 at the lower end and 1 at the upper end. The IJV put 3 sutures, 3 ligatures, 2 at the lower end and 1 at the upper end. And after division, again transfixing suture should be kept here. Okay. And the lower transfixing suture is otherwise called the Houseman suture, because in the there is chance of, if at all there is chance of bleeding is more at the early hours of the morning, the next to the surgery, the morning hours of the day after the surgery. So it is a houseman who is first came to know about this bleeding. So it is called the houseman sutures. Okay. So the next step is division of the lower end of IJV. And after that, we proceed laterally towards the chest extents triangle. Okay, as I already told, this chest extents triangle is a triangle formed by the longus colli and scalenus anterior and its attachment to the C6 tubercle, and the lower border is formed by the subclavian artery. So there, the lower end of this cervical lymphatics come, and the scalene nodes are there. Occult disease can happen there. So that area has to be cleared very clearly. And on the left side there is thoracic duct is there. So inspect and avoid any injury, and if at all any chylous leak is present, that has to be repaired. Okay. So after the dividing the lower end of IJV, the next is supraclavicular dissection. So fifth is supraclavicular dissection. That is, for that, it is this area. So which muscle is coming? That is omohyoid. So this omohyoid has to be divided. Okay, and it has to be retracted upwards. So if you cut on the tendon of omohyoid, the bleeding will be very much less, and the transverse cervical artery and the vein will be encountered there. So that has to be tackled. So cut the omohyoid and retract it upwards. And medial to the omohyoid and lateral to the interjugular vein, the fascia overlying the fat pad has to be incised, and the fibrofatty tissue there should be dissected up. And dissected, and with ideally with the, if you are using a swab, the dissection will be more easy. And the limit is the prevertebral fascia, and the prevertebral fascia should not be broken, or it should not be breached, because if you breach the prevertebral fascia, there is chance of injury to the phrenic nerve and brachial plexus, which lie below that. Okay, so in the supraclavicular dissection, the limit is the prevertebral fascia, and in that area divide the omohyoid and retract it upwards. So once you complete with the supraclavicular dissection, go upward towards the posterior triangle, towards the 5. Okay, so it is posterior triangle. So before starting dissection of the posterior triangle, you should identify spinal accessory nerve, because you should remember that spinal accessory nerve is actually forms the roof, lying on the roof of posterior triangle, and all important structures are lying below or caudal to the spinal accessory nerve. And the spinal accessory nerve emerges from the lateral border of sternocleidomastoid at its upper 1/3 and the lower 2/3, and that point is called the Erb's point. And in around 80% of the cases, this spinal accessory is lying 1 cm above the point of exit of greater auricular nerve. So, and in 20%, the spinal accessory will be below the level of greater auricular nerve. So, that is a most easiest way to identify the spinal accessory nerve. And there are so many techniques to preserve the spinal accessory that I will explain along with the modified radical. And after that, the fascia from the anterior border of trapezius up to the tip of mastoid. From the anterior border trapezius up to the tip of mastoid has to be divided, and fibrofatty tissue along with the lymph node has to be dissected. Okay, and then we are going to the third corner of consternation. What is there? It is the sternocleidomastoid upper border. So after that, after posterior triangle, this upper border of sternocleidomastoid has to be divided under tension. Okay, and the bleeding has to be controlled. And then what will you see? We will see the upper border of internal jugular vein, isn't it? So next is dividing the upper border of IJV. Okay, so from the posterior triangle, after completing the posterior triangle, divide the upper end of sternocleidomastoid and then ligate and divide the upper end of internal jugular vein. And that is by after cutting the sternocleidomastoid, this posterior belly of digastric is retracted anterosuperiorly, and then you can see the upper end of internal jugular vein that is ligated and then transected, divided. Okay, there care should be taken to preserve hypoglossal nerve, because hypoglossal nerve, it turns sharply over the branches of external carotid artery to reach the submandibular triangle. So at the upper end of IJV, care should be taken to preserve the hypoglossal nerve, and along with that remove the retropharyngeal and parapharyngeal lymph nodes. Okay, so that is with the upper border of IJV. Then coming to the level 1, that is the submental and the submandibular triangle. So in submental, first identify the anterior bellies of digastric, then retract it laterally and remove the fibrofatty tissue there up to the lower limit being the body of hyoid bone, and then identifying the anterior border of submandibular gland. Here comes the submandibular gland. So identify it. Submandibular gland will be there, and the muscle there coming is the mylohyoid muscle. So after identifying the anterior border of submandibular, go to the posterior border of mylohyoid and retract it and go deep to or inspect deep to mylohyoid muscle and remove the fibrofatty tissue there. And also if you retract the submandibular gland downwards, two important structures are coming there. One is a lingual nerve and also the submandibular ganglion. So lingual nerve has to be preserved. Okay, care should be taken to preserve the lingual nerve. It should not be injured. And you will also see the duct of submandibular gland. So the submandibular duct has to be divided between ligatures, and if you retract it upwards, the hypoglossal nerve and the nerve can be seen coming from the posterior part. It is coming anteriorly and lies parallel to the tendon of digastric. This way. Okay. So in the submandibular bed, there is hypoglossal nerve is there in the lower border, and towards superiorly there is a lingual nerve. Both has to be preserved. And after ligating the submandibular duct, the submandibular gland is also removed in total as a specimen. So we have removed the 1A, 1B, and along the chain, jugular chain, that is 2, 3 and 4, and in the posterior triangle 5. So everything is removed in toto. So that completes our dissection. Then 8th is dissecting the submandibular triangle, that is closure. And once the dissection is completed and the specimen is removed as total, a warm pack is kept in the this area and hemostasis is looked for, and ask the anesthetist to do a Valsalva and look for any bleeding point, and the whole area is first cleaned with the saline and then with sterile water, and hemostasis is looked for. Okay, after that skin is closed in layers with after putting a drain. So this is radical mastoidectomy. So position of patient, incision, elevating the flap in a subplatysmal plane, and incising the fascia over the sternocleidomastoid from upper to the lower end, then dividing the sternocleidomastoid at the lower end, identifying the IJV, then ligating the lower end of IJV, going to the chest neck triangle and supraclavicular dissection, then posterior triangle dissection. Upper end of sternocleidomastoid is removed along with the ligating the upper end of IJV, then the submandibular dissection. After that, closure. So this is radical mastoidectomy in a simple way. Okay. So coming to the regarding complications that we can discuss after completing modified radical and selective neck dissection, because the complications are almost the same in all neck dissections.